a neurologist from Ohio State University. You're a graduate of Eastern Virginia Medical School and attended George Washington University for residency and clinical care fellowship at WashU for fellowship. You worked previously at the, bio just disappeared on me, Trauma Center in Baltimore for acute care surgery fellowship. You serve on multiple national surgical societies and lead a yearly surgical mission trip to Guatemala. Her research focuses on improving outcomes for traumatically injured patients and reducing exposure to opioids. Dr. Valdez speaks nationally on physicians' mental health, and she is here to share her personal story and message of hope for physicians in crisis. Dr. Levine, as I said, gastroenterologist, chairs the Committee for Practitioners' Health at Ohio State. He's been on the committee for 26 years and has been the chair for the last 10 years. He's also chaired the Committee for Practitioner Effectiveness for the last 16 years. Today, he's also going to talk about the experience that he has had with the Committee for Practitioner Health. So thank you so much for joining us today.
Thank you. Thank you. Good morning. If you can't hear me in the back, just let me know. I'll try to project, treat it like a trauma bay, and see if we can get everybody on the same page at the same time. So I'm Carrie Valdez from Ohio State University. I'm their level 1 ACS Trauma Center. I'm the medical director there. I'm exquisitely comfortable in this room because I went to medical school specifically to become an OBGYN doctor. I chose IVMS because we had the Jones Institute, which is the first IVF fertilization institute in America. Fell in love with it. It's all I ever want to do for my whole life. My mom is a labor and delivery room nurse. I grew up on the wards throughout the 80s and 90s when you could still visit your mom and bring donuts. And my first surgery was a C-section. My mom was the circulating nurse. Her best friend was the scrub nurse. And then all three of us, our OB was Dr. Jewel, and we were doing a C-section together. I promptly passed out during that case. And look at me now. So I fell in love. Unfortunately, surgery became my mistress, and I ended up falling in love with her and marrying surgery. So I went that route. But when I walked in and you were talking about pulmonary artery catheters, I was like, oh, I'm really at home now because as a critical care doc, I was like, okay, this is my space. These are my people. So we'll share today. I'm going to spend probably 30-40 minutes of my time going through my story and sharing my experience. And then Dr. Levine will share kind of how we do it at OSU and what the resources and support are. All right, so this is me. I went to medical school pregnant. That was a surprise to, I think, everybody who had accepted me. Had Cameron, who is my son, during my first year of medical school. My daughter, Julia, I had during my critical care fellowship. I did as PGY4. And then that's my husband. He is slowly becoming a Buckeye. He graduated from the ROTC program at University of Michigan and was in the Navy, but we are slowly bringing him into the Buckeye fold. This is residency. This was my life. My husband was stationed in Norfolk, Virginia as a naval officer, and I had gone to Washington, DC to train at the George Washington University. So I brought my son with me, an incredibly generous au pair that I owe my world to. And then Cameron just came with me to every single event. I think this is one of our residency recruitment centers. Residency was also very messy. This is my chief. Could not keep his white coat clean. This is kind of becoming a running joke of what Josh has spilled on his white coat this morning. It looked like it was a cup of coffee. And then patients are messy. I mean, they just pee all over the place. So I thought that was kind of funny. Residency is also hard. Being attending is also hard. It became almost a theme in our residency. We take pictures of each other falling asleep, right? These are my two attendings here on the left as my co-chief in the top right. And then this is me practicing for my oral board exam. I couldn't even keep myself awake when I'm studying for like the most important exam I was going to take in my life. So if you are exhausted and you do fall asleep, it will not hurt my feelings. Thank you for listening to yourselves, listening to your bodies, because you work the same shifts and patterns that we do as trauma surgeons. So I feel you and I understand what you're going through. So let's get started. My name is Carrie and I'm an alcoholic. Before I attended medical school, I would call myself probably a heavy drinker. I had a little more tolerance than all of my friends did. I was married to a guy in the military. All of our friends were dual income, no kids, right? So we worked hard, we partied hard. Went to medical school, drinking got under control better. I had a pregnancy, I had a new baby, I'm a medical student. And then I got into my third year of medical school. I did my OB rotation, the rotation, this thing that I've been like looking forward to for the past 15 years, right? And we had a cluster of fetal demise or infant mortality, and we had 7 deaths while I was on service over those 8 weeks. And at the time, I didn't talk to anybody about it. I didn't know to talk to somebody about it. You know, as I was on service, I think that we sometimes tend to view medical students as there to observe my experience without recognizing that I'm also having the same experience, right? This is the first time I've had patients. This is the first time that I've celebrated their joys with them and then sat with them when they've had disappointments. So we didn't have a system in place to discuss it. I did 2 weeks at a private hospital, 2 weeks at a public hospital, 2 weeks in outpatient clinic, 2 weeks in MFM. So there's no one person in my world that is kind of watching the arc of my experience over those 8 weeks. My surgery rotation was next. Unfortunately, fortunately, fell in love with just being a general surgeon and leaving kind of outpatient benign gyne behind. And at the end of my surgery rotation, we had a patient. I was allowed to do some maneuvers in the OR. Those maneuvers caused some postoperative bleeding, and she died in PACU. She was 34 years old and had come in for an elective flat chole. And again, no discussion really about what had happened, right? I was just there to observe the experience. I was invited to go tell the grandfather or the grandmother and the son that mom had died. So I got to be there for that, but no, I didn't know any better. I just kept observing, right? So my drinking became heavier and heavier over the next few months until I was drinking to the point of being really intoxicated or blacking out on a daily basis. Asked for help at the end of my 3rd year of medical school and went to a 28-day inpatient treatment facility. Great.
Valdez, can you talk a little louder, please?
Sure can, and thank you for saying something. Went to a 28-day inpatient treatment facility at the end of my 3rd year of medical school. And don't you worry, I was reassured we're keeping this quiet. We're not going to tell anybody. You're just going to go, you're on service, nobody will notice. We'll have you come right back in and rotate, just pick it up and keep going. I just take fewer weeks of vacation during my 4th year. And that's how it felt. I stopped drinking. I understood what recovery was. I'm good. Went right back into medical school, went to residency at George Washington. And then I stayed abstinent for the next 6 or 7 years, right? I didn't drink at all in residency. I was successful in residency, published papers, won awards, got a fellowship into shock trauma, which is arguably the best trauma program in the world. I got to attend right after the Baltimore riots. Terrible for the city, wonderful for training. We did a lot of high volume penetrating trauma for 12 straight months. And then I became an attendant, right? I finally kind of made it. All that stuff that had happened in medical school, there was a reason, there was a cause, there was a blame, right? Fast forward to 2017, and I'm at a New Year's Eve party and someone had Grand Marnier. I like Grand Marnier, so I poured a drink. My world didn't crash down around me. It was okay. A few weeks later, stopped by and got something to drink at the store on the way home. A few weeks later, did it again. A week later, did it again. 3 days later, did it again. And within the course of about a year of daily drinking. But life was like manageable, right? I've got this very impressive CV. You've seen my beautiful children. My husband's now retired from the Navy. Like, we've done it. Like, we're no longer drowning in the debt of medical school and residency. But I was drinking every day and I couldn't stop. And this is going to progress until a crisis in 2023, which we'll get into. This is my life. I don't know if anyone can relate to this. Ideally, we want to sit in the yellow zone, right? Just enough stress to be like competent, achieving, and feeling like we've got purpose in life. Generally, I sit somewhere in the dark orange to red at all times. And so did everybody else around me. So when I would get really bad, quote unquote, really bad, it was awful, I'm in deep dark red. Make some adjustments, come back into orange, just like everybody else around me, and it felt like that was my normal. I remember learning how to cry out of one eye during a case so that my attending would not be able to see me during the lat chole, but he's hurting my feelings and breaking my heart. My best friend in residency, Hope Jackson, we would sign notes. This was back in the day with paper charge. We'd be on the nursing station writing out our notes. She's like, "You crying?" I'm like, "Yep." She goes, "You faking that you're writing a note?" I'm like, "Sure am." "You?" She's like, "Yep." I'm like, "Right, pull it together." Right. And fellowship, we had we don't do this anymore, but we kind of had all the drugs we wanted in our pocket. If someone's being a little bit misbehaving, here's a little propofol, right? And we would have these vials and vials of propofol or ketamine or whatever, or just kind of like whatever's in our pocket, we'd dump to the top of the filing cabinet. And we would joke around about one of these days, it's all for me. And that's how we'd get through the day, because we just kind of set living in this. But at some point, this is unsustainable. And I'm going to break. All right, let's step back a little bit into some academic part of it, right? So what is alcoholism? We now call it alcohol use disorder. It's patient-centered language. These are the 5 things that we're taught in medical school. These black and white words are so intimately personal to me. The loss of control would be that sensation of, I can keep it together. We've got a residency dinner, or I'm on call tonight. But periodically, I could not keep it under control. And in my mind, the whole time I'm thinking, like, I've got to figure this out. I'd already sobered up in med school. Now I'm an attending. I know the solution, but that didn't work. That solution didn't work. I've got to figure this out. I've got to sleep more. I've got to do yoga. I've got to meditate. I need to be mindful. God love mindfulness, but man, it was really popular when I was in crisis, right? It wasn't enough. There was not a gratitude list that was going to pull me out of this, right? Preoccupation. I didn't know it was preoccupation. I needed to get home. Shift is over at 5:30. I'm out the door. I needed to get home, right? I needed to find a solution to relieve this internal angst and stress. Okay, obviously tolerance and withdrawal are part of my story. The use despite negative consequences. I never had a legal consequence. I never had a medical consequence. Disrupted sleep, not being a great mom, not being really present. Those are my consequences. And I continue to use, even though I had just an inkling of insight that this might be what's going on in the background. This is my favorite definition of alcoholism. If you honestly want to, you find you cannot quit entirely, or when drinking, you have little control over the amount you take, you're probably an alcoholic. If, when I honestly want to, I find I cannot quit entirely, or if when I'm drinking, I have little control over the amount I take, I'm probably an alcoholic. The only definition I ever needed to hear. When I read these lines, yep, that's me. All right, so let's see where I fit in amongst all physicians, right? Because my entire experience has been that I'm alone in this. I don't see anybody else in recovery, and I don't see anybody else going through the same things I am. I've got to like figure this out on my own and keep it a secret, because if you figure this out before I figure this out, I'm in a lot of trouble, right? So attendings versus residents. This was a systematic review over 10 years. What's the data? And so for problematic alcohol use, attendings and residents, no difference. And it didn't make any difference in age. We are never too young to develop an alcohol use disorder, and we're never too old to recognize it. Increasing problematic use over 15 years, the use has gone up. And then there's in the United States as a whole, men's drinking has increased about 15%. They started higher. Women's drinking has increased almost 57%. And women have this concept called telescoping. As a group, we tend to start problematic drinking a little bit later in life. We experience consequences a lot sooner. Okay, so our period of time that we're going to be able to sustain heavy alcohol use is a telescoped view compared to men. Surgeons versus non-surgeons. OBs are called surgeons in this review. We have a higher risk. OB, anesthesia, us, ER, and veterinarians were the highest risk group. All right, these are the intertwining factors that impacted me. There are many, many co-definitions and co-diagnoses that will go with any mental health disease. I want to spend a few minutes today. We're going to talk about some of these, particularly post-traumatic stress disorder. Dr. Cunningham is an endocrinology surgeon by training, and she was the president of the Association for Academic Surgery, which is one of the most premier bougie academic societies that someday maybe I'll get into. And she was the president, and one of her roles that she did is she surveyed academic surgeons, program directors, associate program directors, and just wanted to understand what is the current state of mental health in these high achieving surgeons who like made it in academia, right? Here's what she found. Of 630 responders, 16% screened positive for depression. Okay, and these are well-validated screening tools that are being used. 17% of these surgeons screened positive for post-traumatic stress disorder. 11% had hazardous alcohol use. 14% reported suicidal ideation in the prior year, and 10% in the past 2 weeks. And 60% had a colleague who had attempted or had died by suicide. When this data started coming out, it highlighted for me the problem. It also highlighted it's not just me all by myself trying to figure this out. It's happening all of us around us, our colleagues or ourselves. So what is complex PTSD? It's a little bit of a new phrase I didn't understand. So this is PTSD symptoms, right? So PTSD, oops, I'm a slide off, excuse me. Complex PTSD is maintained by 3 pillars. I had to be taught this. So 3 pillars. 1, repeated harm by someone or something you trust and you feel trapped. PTSD tends to be an event, an assault, a car accident, the death of a close family member or friend. Complex PTSD is repeated harm by someone that you trust and you feel trapped. And I want to drill these definitions down because it made a difference in saving my life. So repeated harm by someone or something you trust and you feel trapped. Throughout this cycle of that stress burnout curve, it has never once occurred to me to quit. What else would I do? Wait tables? It's my only other skill set, right? All right, symptoms, this is where I was before. So these are symptoms of PTSD when there's like an event, right? Anxiety, hypervigilance, right? Difficulty sustaining relationships. We all have a very well-developed skill of meeting somebody and within minutes, we're doing an exam on the most personal part of our bodies, right? We can create a relationship very easily, but sustaining that relationship. I didn't have, as I look back through history, I didn't have a lot of like sustained friends. I had a couple friends here and there. I was friendly with everybody, well-liked and well-loved. I liked everybody, but like a sustained relationship was something I was having a difficult time doing. As complex PTSD symptoms were getting worse, excessive reactivity, meaning great is awesome, bad is awful, or no emotion, flat. I can code somebody, watch them die in front of me, take off my PPE, walk to the next room and consent somebody for a lap happy and keep going. Okay. I think you all have a lot of the same experiences in the world of obstetrics and gynecology. Identities of self, shame, guilt, failure, worthlessness, and now he's having difficulty forming relationships. Right, so you had complex PTSD with someone who's actively using his alcoholism. I hate my job. I hate my program director. I hate my boss. I hate my colleagues. I hate my patients. There have been nights when I have stayed awake wondering if that person would just die so I didn't have to round on them in the morning. Blunt, honest truth. Okay. I didn't have any insight that what was going on was much more than just I'm a bad doctor. This is the definition of shame I use. I use it with my kids. I use it everywhere. Shame is should have already mastered everything. Okay. I wish I would have known so-and-so liked pop music in the OR because that put him in a bad mood. I wish I would have remembered the antidote to metoprolol. I wish I'd paid more attention to a pulmonary artery catheter lecture because now I'm staring at a screen I don't understand. Right? I should have. That I had to understand was the definition of shame. If you had asked me before I went to treatment, what are you someone who's filled with shame? I'm like, no. Have we met? Carrie Valdez. I don't feel shame. Sure as heck I do. All right, going back to Carrie's data, Dr. Cunningham. So this is how she screened practitioners or the surgeons for PTSD. She asked them to survey, consider events that you would consider traumatic, if you've had traumatic experiences. And in the past month, I'm not gonna ask anyone to raise their hand, but just contemplate these questions yourself. In the past month, if you had nightmares about the event or thought about the event when you didn't want to. If you tried hard not to think about events or went out of your way to avoid situations that reminded you of events. Boy, did I do that. I'd do anything to not work with a certain surgeon because it felt terrible every time we did. Patients would die in a room and I wouldn't pick up that room on rounds. I would take stairwells to avoid areas that had caused me some great harm. Been constant on guard, watchful, or easily startled. I startle like someone who just got out of prison. Felt numb or detached from people, activities, or your surroundings. Felt guilty or unable to stop blaming yourself or others for the events and any problems the events may have caused. If you said yes to 3 or more, for women, it's 83% sensitivity and specificity for the diagnosis of post-traumatic stress disorder. 17% of these respondents screen positive. Okay, for men, it's about 87%. You're more likely to screen positive for complex PTSD if some of the traumatic events occurred before training. And my interpretation of that is likely what's coming through is complex PTSD. We all bring ourselves and our lives and our experiences to the table, and with continual experience of trauma, it can lead to a complex PTSD and clustering symptoms. But I'm here to talk about my alcohol use disorder, right? So what does this all have to do with that? So how does PTSD have anything to do with alcohol, right? The best studied group of people with PTSD are going to be the veterans, right? So this was a study It was based on the fact that we previously demonstrated there's a high co-occurrence of PTSD with veterans and heavy alcohol use. Why? Right, so over the course of 12 months, they evaluated these veterans, right? There's an interview style survey, and they're looking for PTSD symptom clusters, right? So those 2 columns of symptoms I listed, when those symptoms tend to cluster together. They also interviewed them and asked them about their craving for their drug of dependence, and they did this over a scope of 12 months. What they found is that the avoidance symptoms were significantly associated with alcohol craving. And of all the drugs available, alcohol is the drug of choice. When they asked the veterans why, this is what they reported. It alleviates these thoughts, feelings, and external reminders of trauma. This has been my experience. I can't explain to you what is going on, but I know when I get home and I have 4 ounces of room temperature vodka in a coffee cup leaning against my kitchen counter, then in half an hour it settles, and I feel like myself again. We need more research and understanding on serotonin phenotypes and the reasoning and the why. That's academic. It'd be great. Maybe we find some treatment options that are helpful. I don't need to understand the why. I just know that this is. So as I had abstinence and periods of abstinence, my PTSD symptoms clustered. No wonder I returned to use. I'm seeking a relief from an internal disruption that I don't understand. And I have a solution. I just got to figure out how to make that solution work with this world and life I've created. I can keep it together for a little while until I can't, because I'm an alcoholic, right? It is a chronic, progressive, relenting disease unless I get treatment. All right, so what happens to me at the breakdown? Let's talk about it. So in 2023, I want to walk you through 3 events that ended up saving my life. Heading into this period, I was sober, working program of recovery, and my complex PTSD symptoms were worsening without any insight. So in January 2023, this is Dr. Cunningham. She chose to use her presidential address at the AAS to share her story. She has alcohol use disorder, she has post-traumatic stress disorder, she has depression, she has anxiety. This is one of the most highly achieving female surgeons using this platform to just share my story. I no longer saw Dr. Cunningham, I saw Carrie. Cool that we have the same name, right? I can relate to that. And she shared her story, and I was like, that's how I feel on the inside, even when I'm sober. Right? So she got up on stage and used that platform to increase some education and advocacy. I watched the video, I was sober, right? I was like, that is incredibly brave. Next, the Disposables came to OSU. This is in August of 2023. The Disposables was an art exhibit that was put together by Jeremy Rosario. Jeremy's on the left. He wanted to use his art to increase the awareness of physicians in dying by suicide. 300 to 400 physicians per year in the United States will die each and every year by suicide. And so he took 4 portraits of physicians when they were smiling and happy and used all the disposable instruments that he could find, Foley catheters, needles. And so these are all these 3D portraits because he felt that sometimes we are treating our physicians like they're disposable. Right, so that was his art campaign. The gentleman standing in the center there is Danny Eiferman. He was my partner. I was on call the night that the exhibit came. Danny went, and he shared about it the next morning at Morning Report. And just knowing that my partner had been there, that he'd gone to support this event, ultimately in the future is going to let me know that there is a safe place within OSU if I ever had some difficulty. And lastly, in September, the State Medical Board of Ohio increased their confidentiality monitoring program, meaning I can reach out to our PHP program, self-report, they will help me, and it stays confidential. This was the biggest barrier for me reaching out for help. I had tried treatment, I had tried recovery programs. I was sitting in September and October, I'd started relapsing at this point, believing that like I just suck at recovery. Maybe I can keep it together until my daughter gets into college. Maybe I can keep it together until, and that line got shorter and shorter until it's like she's 11, maybe until she starts her first menstrual cycle. Can I just hold my shit together? So October 3rd, 2023, I'm heading to work, hungover, exhausted, burned out, and fried. I didn't know what to do. There was no out. I was on a 17-day run of shifts. I had a 7-week period with 1 single day off on a weekend. And I was right in the middle of it. And I turned the corner and I was heading to work, and there's this bridge, and I can feel my right foot kind of pushing on the gas. And I'm starting to think, I wonder if I can get fast enough to hit the bridge post. And I thought, should I take off my seatbelt? Gratefully, my next thought was, That's really gonna hurt. And then I saw OSU in the background. And I thought, and if I survive this, they're gonna take me to work. And I have never felt more hopeless and despondent in my life, right? I went to work, and on my way, I started thinking, maybe I should go to the other side of town, to another trauma center. No, don't go by a trauma center, go rural. What's rural? And I'm thinking about how can I get this done and make sure it gets done? I didn't think about my family. I didn't think about my colleagues. I didn't think about my reputation. All I could focus on in that moment was I just need a break. I just need this to stop for a second so I can breathe. And then I went to morning report. Ran the list of patients, rounded on everybody. Talked to my colleagues afterwards, they had no idea. No idea that afternoon I was gonna be calling for help. Because we're good at that, we're trained at that. Right, I've got my work hat, my work face. That afternoon, I called a friend in recovery who's also a physician. I said, Dwayne, I just don't know what to do. I cannot stop drinking. He said, please call for help before you hurt yourself or hurt somebody else. So I called our Ohio PHP, got a voicemail, hung up. We're not doing this on voicemail. All right. Dwayne helped me call back. He stayed on the phone with me. And then I left a very minimal voicemail. You can call me back at this number. I'd like to talk to you about a physician I know about who might need some help. Right. Nelson, who's the clinical director of the Ohio Physician Health Program, did call back. And within minutes of talking to him, that relief that I'd been seeking for so long came. It was over. It had stopped. I don't know what's happening next, but it's over. Nelson helped connect me with the Ridge, which was my treatment program. Staff at the Ridge helped me tell my family. I had to go tell my daughter, my husband, my son, I've relapsed. They didn't know, and I need to go to treatment. The next morning, like a good alcoholic, I got nice and ripely drunk and went to treatment. Okay, that's how sick I was. Even asking for help, even help is a few hours away. I didn't know what else to do but to drink the whole way there. So treatment, I keep saying rehab, I'm a little old school. It's treatment. So we're talking about patient-centered care. We do say, so somebody's gone to treatment. I have been treated for my disorder and my disease, and I'm still learning how to say that. So this was the Ridge. This is where I was treated in the smaller building. So we do detox. I did detox, went through withdrawal. They were incredibly kind and helpful and used medications to get me through it safely and as comfortably as possible. And then I stayed inpatient for 45 days and met some of the most incredible counselors and staff. No after-school special has anything on this. All right, Goodwill Hunting, they don't have anything on this. Okay, these people were smarter than I was. They had met me before. They knew my story. They knew my defenses, and they diagnosed me with PTSD. The first time I've ever looked at a practitioner who said anything to me medically, and I used the big words and swore back at them because I didn't believe them. I'm not some war vet. What are you talking about? I'm just a trauma surgeon. Like, you are a trauma surgeon. It's like, this is, anyway, I won't use all the words, but I use a lot of the big words. But they gave me resources and they gave me literature and they helped me to understand, why is it that when I honestly want to, I can't quit entirely? Why do I keep coming back to alcohol as my solution? And they taught me that if I don't treat complex PTSD, I will never recover from alcoholism. If I don't treat alcoholism, I'll never recover from complex PTSD. This was a new diagnosis I had no idea I'd been dealing with, right? And they walked me through that. I finished the inpatient treatment, and then you do intensive outpatient treatment. So 3 days a week for 3 hours. And I got a trauma therapist. And she helped walk me through it. And even just the insight of understanding was relieving. I thought I was going to struggle against that grind of relapsing for the rest of my life. And she's this incredible woman who understood. So then I need to start talking about coming back to work. Right, so I did my intensive outpatient treatment, and I'm ready. So OPHP, Ohio Physician Health Program, is a 5-year contract. There's a couple of requirements, right? So you need to be compliant with the people who are helping you save your own life. First requirement, maintain abstinence. Okay, fine. Great, we're gonna take alcohol as a solution off the table. I can maintain abstinence, right? 3 recovery meetings per week, and we're gonna go over what those meetings are. Random drug testing 2 to 4 times a month. There's a little app. I click on it every morning. You have or have not been selected for drug testing. If I'm selected, I let colleagues know. If I'm on admin, I just go. If I'm on a clinical day, I just let them know. I got to pop out and pee and call. Takes a half an hour, and it is like the bougiest, nicest, like breast care outpatient clinic kind of clinic you can imagine. So I go in, say, hey, check in, pee, leave. Super fast and easy, right? And then a quarterly meeting with the case manager. It's a Zoom meeting for half an hour. We just touch base, paperwork, compliance, questions, issues, anything that you need. It's not onerous. Every state has a PHP program or a state medical board, and every state's going to be a little bit different. So this is my experience in Ohio. It'll be different kind of everywhere you go. Recovery support groups. So I don't speak for any particular group. I have tried them all. I think get in where you fit in, right? Whichever one speaks to you. If you go to a meeting and it's not your jam, go to a different one, right? They're all different. Alcoholics Anonymous is a 12-step recovery program that's the most common and most popular and probably one of the oldest ones that's well established, right? They have meetings in person. If you're not quite ready for treatment, but you have concerns, maybe some thoughts, maybe I am an alcoholic and want to check it out, they have open and closed meetings. Open meetings are open to anybody. When I was a medical student, we were required to go to 2 meetings. You find an open meeting and you go. So you can just kind of sneak in there and check it out, right? Don't need to identify as an alcoholic or a desire to stop drinking, just see what's going on. They have closed meetings that are specifically for people who identify with a desire to stop drinking. There's caduceus meetings. These are essentially AA meetings that are designed specifically and closed to only healthcare providers. Okay, idaa.org is their website. It can be a space that I find I can share about the events happening inside the hospital that impact my alcoholism, and I can do it in a place that's appropriate and safe to do so. Recovery Dharma is a Buddhist-based practice of spirituality and recovery. recoverydharma.org. And then Smart Recovery is a cognitive behavioral therapy and motivational interviewing, excuse me. It stands for self-management and recovery training. This is a more of a CBT-based, not a spiritually based program of recovery. I think there's beautiful things about all of these and wherever you can fit in. The websites are on there. Many of them have online meetings, which makes it great. I'm on call, it's 11 o'clock. I'm free to click on an online meeting. Okay. Most of them also have in-person meetings. I took a look. I think the first one Alcoholics Anonymous, there's 87 AA meetings in the Phoenix downtown area every single week. Okay, so there's lots and lots of opportunities. So this is this place that repeatedly harmed me, and I trusted it. And I'm going to go back. And that was a big deal. I've met all these requirements. I've gone to the committees. Dr. Levine's going to share more about what that side of the process is like. And I decided it's time to recover out loud. I've been around long enough to know that for me, trying to keep my recovery separate from my work life, I couldn't do it anymore. It was like leading a double life. I needed to be able to share with my colleagues and friends, I can't go to the residency interview dinner tonight because I need to go to a recovery meeting. That comes first and foremost, and it's non-negotiable, it's a priority. I share with them that I'm going to get drug tested. I don't have to. There's no requirement, nor is there an expectation that you're open about this at all. But for me, it was time. And as I went through inpatient and outpatient treatment, I kind of looked at the course of my life and my recovery journey. I feel that there's likely somebody else out there who is feeling what I felt. And I want to be able to stand up and say that we can and do recover from alcoholism. We can and do recover from PTSD. And so I've chosen to share my story and be more open about it. I told all my colleagues when I got back, we had a Zoom meeting, which was awkward enough, but that's where we meet these days, right? Everything's on Zoom. I'm so grateful you're here in person. It was so well received, nothing but support. OSU, I think, should be the gold standard of how you should be handled, at the administrative level. And then the most curious thing I never anticipated happened. Over the next 2 or 3 months, people would come and share with me their stories of recovery, or their spouse, or their parent. And I didn't even know I'm working in the midst of all of these people who are in recovery. And when we walk past each other in the hallway, there's a sense of solidarity and this just this feeling. You're here and I'm here, we're doing it together, and I'm not alone in this, even when I'm having a great day, just to see each other, right? Having Dr. Eiferman go to that disposables art exhibit, I know I can walk into Danny's office at any point and say, I need a minute, right? The fact that he went. So if you've come here, share that you were here and talked about it. You or one of your colleagues or friends may need to find your office as a safe space, or your call room, or your OR. But just sharing that we're here and supporting and advocating for it. If you're suffering from alcohol use disorder, There's a solution and there is hope, I promise you. So I'll leave this information up here. Feel free to take a picture if you'd like, with the resources that are here, my information. And I want to just leave you with this. If you are an alcoholic, I can make you only one promise today. You never have to drink again, even if you want to. Okay, we recover from this. And there's so much hope. And I have gone from this woman who just didn't want to die, to this woman who wants to live, who like embraces and loves life. Thank you so much for letting me share.
Thank you, Dr. Valdez. Can you all hear me back there? All right, good. So I'm Ed Levine. I am a gastroenterologist, and my story is my career, my whole adult life, most of it has been up at Ohio State. I started there as an undergraduate and have been there since. There were 6 years in between that I was away, but that's where I worked. What I'm going to talk to you about is how do we do this? Okay, so Dr. Valdez started with the problem. This is the situation. This is the situation that we're in. And so how do we as an institution address this and help the provider? Okay, the hero in all of this, in terms of the story that you just heard, is Dr. Valdez and every provider. Okay, not just her. Okay, this is about you. This is about the practitioners at Ohio State and everywhere. How do we help support people through this as an institution? All right. It's been estimated that about 15% of practitioners during their career will be impaired, about 15%. And the AMA defines impairment as the inability to practice medicine with reasonable skills for any health-related condition. And as you heard about Dr. Cunningham, title, stature, salary does not prohibit anybody from developing any health-related issue, whatever that may be. Okay, we think about practitioner wellness as a recent thing with burnout. You guys ever hear a lecture on burnout?
No, we do computer-based training modules now.
But it's not new. Okay, this is Dr. Osler, William Osler, and he said that the duty that the physician is most derelict in is their duty to themselves as it relates to self-care. So at Ohio State, we have a committee for practitioner health. It started about 35 years ago. As mentioned, you heard before, I've been on the committee for 26 years. I started in 1999. I've chaired it for the last 10 years. What is the mission of our committee? Well, we advocate for our patients first and foremost, okay? To deliver great care, practitioners, it's hard enough, but practitioners need to be in excellent health in order to deliver that care. We advocate for the medical center to be known as a medical center that takes practitioner wellness seriously. And then in addition, we advocate for the practitioner. Okay, this is the situation. This is the problem, if you will. It's not a problem. This is the situation. Okay, how do we help? Particularly by the time they come to see us at our committee, okay, the practitioner and our committee have the same goal, and that is to get them back to work in the clinical environment in a fashion, in a manner that supports their health. Remember this slide because you may see it. You will see it. Okay, so this is our committee. You can see that it started in 1994, and I'm just going to go through some of the statistics about the committee. Everybody loves statistics. You can see we started in 1994. I started in 1999. We met quarterly. Our committee met quarterly, okay? Well, over time, that changed because our medical center has changed. The number of faculty that we have changed. Now we have a standing meeting every week. Sometimes we have to meet twice a week. Sometimes we don't have to meet. We cancel the meeting. These are the numbers you see here of new people that we meet with every year. There are many more meetings with that because it's not a one and done. We don't meet with somebody and say, oh, good luck, let us know if you need us. We meet with them and then we continue to meet with them periodically over several months to make sure that things are going well. In the case of a substance use disorder, and if they're working with Ohio Professionals Health Program and they have a confidential monitoring agreement, we meet with them for the duration of that confidential monitoring agreement. Towards the end, it's about once a year, just to keep things on track. This is all said here, but in terms of the rank of the people we meet with, in terms of APPs, physicians, trainees, I want you to focus on that circle area there, okay, even though it's offset. Trainees, 60% of the people that we meet with are trainees. Okay, that when we put this together, that was an eye-opening for us, okay? Why is that? They're younger, generally younger, and they have program directors who are there to help, and if they recognize a problem, okay, maybe you need to meet with the health committee if there's a concern for a health-related issue. Why do we meet with people? The number one reason is a substance use disorder. That's the number one reason why somebody will meet with us. Number two is a mental health disorder. 8% of people will have some physical problem, heart disease, Crohn's disease, whatever the thing may be. And 15% will meet with us for professionalism issues, okay? Difficulty having good interactions in the clinical environment. Now, we have a separate committee from that, which I'm going to tell you about here in a little bit. So why would they be referred to the professionalism, to our committee, if they're really professionalism concerns? And their answer is, this committee started, the health committee started in 1994. The professionalism committee didn't start in 2009. So before 2009, we weren't sure what to do. We didn't know, so we would have them come to the health committee. This is the thing, this pertains to Dr. Valdez, but to everybody who has to take some time off from clinical work, okay, for whatever reason, for whatever health reason. And in order for them to resume clinical duties after they have some time off, there's a couple of pathways that they do, whether they just come back and meet with our committee. We get a letter, a note from their doctor that they're able to resume clinical duties. I talk with the chief clinical officer, and they meet with our committee, and then they resume clinical duties. That's pathway one. That's how most situations occur. Who's in pathway one? Okay, just kind of a routine hospitalization that required, perhaps an ICU admission or a stroke or a minor mental health issue, this type of a thing. What's not included, and we have no reporting for, is an uncomplicated pregnancy, uncomplicated surgery, a routine medical admission. They're in, they're out. Usually it's a few days, a week, whatever. We don't do anything with that. But pathway two, okay, where they go through a different process, there are two situations that occur with that. One, a diagnosis of a substance use disorder. And two, if a patient has a major mental health issue, usually one of two things: an inpatient psychiatric admission or a suicide attempt. Now, under those circumstances, and this is what Dr. Valdez had gone through because of her diagnosis, was pathway two. They meet with our health committee, okay, see how they're doing. I will have received a letter from OPHP, Ohio Professionals Health Program, saying that this person is able to resume clinical duties. Our committee discusses it and approves them to come back. Then they go through basically what amounts to a month-long process of a variety of committees reviewing the situation and making a recommendation for that person to be able to come back. They go through credentials committee because when this happens, their credentials have been suspended for that period of time. Then they go to MSAC, which stands for Medical Staff Advisory Committee, which is populated by the dean, the chief clinical officer, the chairs, and so forth. And then the last committee is with QPAC. We like to use all the letters in the alphabet. Quality and Professional Affairs Committee. Okay, and that's made up of board members. These are generally not doctors that are reviewing this, but board members who will review the situation. And then once they go through this month-long process is when they resume clinical duties. So that is the process. This is, we do this, and we do it for a reason. And everybody, we want to maintain consistency and have everybody go through this process. And we have, whether you're a trainee, an assistant professor, or a chair of a department. we've done this process regardless of their stature. Okay, you've already heard about Ohio PHP. This is an invaluable resource to us at Ohio State, as well to every health system in the state of Ohio. You heard about Nelson Heiss, he's the clinical director there. When I talk to him usually a couple times a week in terms of discussing a variety of the people that we see, where their status is and so forth. And they're very helpful in terms of having an assessment done, arranging for treatment for somebody, and they deal with other things other than substance use disorder. It's mental health disorders, any health-related issue, including professionalism issues, they're very helpful to us. And it's the State Medical Board of Ohio also works with them closely, okay? Not all state medical boards have always been so, I guess, physician-friendly, okay? A lot of them have been described as punitive. Ohio is no different. They've changed over the past few years, and their basically position is, their philosophy is, and how they work is, they want to get out of the business of monitoring, get out of the business of consequences for the state medical board and taking action on people's license. And what they basically say is, as long as the provider works and does what OPHP recommends, that's fine with them. And there's no action taken on their license. Okay, I'm going to veer off here a little bit here, talk about physician well-being, burnout, and so forth, because our committee, as you saw, works with people not only with substance use disorder, any health-related disorder, including burnout. And I know that you've already heard about burnout, and how burnout and impact of work on personal relationships kind of go hand in hand. That if work is affecting your personal relationships, that you're at risk for burnout. And you can see here, the higher that score, your higher risk for emotional exhaustion and depersonalization goes up. And it's kind of across the board, regardless of what area that you're in, whether emergency medicine or the lowest one is pathology, although they're tightly clustered. Now, why do I bring this up? Okay, because our committee, you know, we look at a person's whole health, and we want to make them as healthy and happy as possible. This is a study. It's the Harvard longitudinal study. It's what's known as the happiness study. And it started in 1938. There was a cohort of Harvard undergraduate, and they compared it to basically people who lived in Boston, who were just community people. These were not students at Harvard. And what they did was they looked at happiness. What were important things that kept people happy their whole life, and particularly at the end of their life, okay? And while obviously it's important to not smoke, to drink moderately or not drink at all, to maintain a healthy weight and so forth, this is Dr. Robert Waldinger. This was a TED Talk he gave, that basically the relationships people have with family and friends were the most important thing, period. Who's heard him talk? Who's you know, okay. This is another one, okay, the Carrie Cunningham talk. You can get on YouTube. I would recommend all of you watch it if you haven't. And this one too, Robert Waldinger, his TED Talk on the Harvard study, should be most watched recommendations from me. Now I'm gonna head into a little bit here, still kind of thinking about practitioner health with this study. This was a Joint Commission study, 2008, okay, a sentinel event alert, and they talked about really professionalism, all right, and how professionalism is important. And basically, it was professionalism, they framed it, in my opinion, correctly, was behaviors that undermine a culture of safety. Okay, when teams don't function well, it puts patients at risk for poor care. Okay, now, I'm sure everybody in this room, every practitioner that I work with at Ohio State, whether they yell at the nurses, to use an old trope, or yelling at anybody, or just not interacting well with people, okay, they're truly trying to practice good medicine. They're probably upset because something didn't go the way they want to, but they want to deliver the best care they can, but their behavior sometimes gets in the way and patient care is at risk. Okay, what is the mission of that committee? The same thing. We advocate for the patients that we see, okay, because good team function is critical to providing good patient care. We advocate for OSU to be an institution that is felt to have a good culture and advocate for the practitioner. This committee used to be called the Professionalism Consultation Committee. We changed the name because sometimes people get hung up on words. You start talking to somebody about their professionalism, particularly doctors, and it doesn't go well, okay? It becomes adversarial, or it seems to be adversarial, even though it's not meant to be. So we changed the name to the Committee for Practitioner Effectiveness. It didn't matter. People still don't like to meet with us.
I like meeting with you very much. Like, you make my life.
That was a different committee, okay? That was a different committee. And this is the tie into that committee in terms of practitioner effectiveness. Some people ask me, well, what do you tell them? How do you have that conversation with somebody? Because it's a very difficult conversation to have, okay? And I tell them, I don't tell them anything. I listen to what they tell me. The first thing I ask them is if there's anything going on in them. Is there a health-related, I'm searching for a health-related reason why their interactions are not good, okay? Whether it's a substance use disorder, which can occur, or mental health, or whatever. There's a million things. Maybe their father died, their mother died, they're going through a divorce, who knows what's going on? But asking that question to be able to help them, okay? And maybe, and I don't like to bat people between the two committees, okay, no, let's not have you meet with the health committee. We can address those problems, but that's the first thing I need to know is there a reason why these interactions are not good? Because, okay, to be, when, you know, a highly reliable organization, which Ohio State is pretty invigorating in our culture, you need to hold people accountable because they need to understand we're here to help you, okay? We want you to be effective, but this behavior has got to end. This is not going to continue. It won't continue. And they need to know the expectations, and people need to know the expectations and the potential consequences if it doesn't end. And that's into my slide. I think Dr. Valdez and I are happy to answer any questions or hear any comments that anybody has.
Just a comment, Linda Chambliss, I'm one of the maternal fetal people. A number of years ago, Dr. Kunra, the former chair, and I did a survey of incoming house staff. We both have a longstanding interest in domestic violence, and 19% of the incoming house staff in the given year grew up in a violent home. And, you know, in terms of when you talk about past trauma.
And I think that's a really important point. Adverse childhood events is certainly something that's become more popular in the common language lately. It's almost impossible to find someone who didn't have something they're bringing to the table. Why do I get symptoms of complex PTSD and someone else doesn't? I don't know. I don't know, right? But I have to recognize and accept this is what I bring to the table, right? It's not good or bad. It just is. You know, this is how I grew up, or how you grew up, or how your incoming interns, you know, that was just their home environment, right? I think it's the insight that was so shocking to me. How am I at the time, 45 years old, and feel like I'm hearing this for the very first time? How did I not know any of this was even out there, right? My mom has, she had stage 3 rectal cancer when I was a first year medical student, and surgery and chemo and all the rest, right? And they told us at the time she had an 8% chance of survival. Yeah, Janet's fine, she's alive and kicking and doing great. And that was 20 years ago. And I knew at the time my risk of getting colon cancer was 8%. Right? If you go deeper into Dr. Cunningham's data, if you have alcohol use disorder and you have complex PTSD, your risk of having either suicidal thoughts or a suicidal event occur is 48%. So my risk of colon cancer is 8%. And we all know this, and it's my history. And like, you better believe every 3 years I have my colonoscopy for my gastroenterology friend on Wednesday. Every 3 years, and I get my colonoscopy because we're going to catch that 8% risk I might get colon cancer. Never once did I have an idea that I had a 48% chance of having suicidal thoughts or an attempt. right? So I think knowing and understanding kind of our history and how it all ties in together is just critical for a little bit of insight and prevention. Thank you for sharing it. Thank you for doing that survey.
Yeah, no, we were, astounded 19% of the incoming house staff reported growing up in a violent home.
Yeah.
And that was all, we surveyed everybody, all the interns. We didn't actually look and see, if there was any kind of specialty driven thing or whatever that, made people choose one or the other, but, it was quite illuminating to us.
And your thoughts, comments?
I have a comment. I feel like for me, I pride myself in compartmentalization, right? So I
A
feel like,
well-worn group, we all have, I hear you.
yeah, and we're like, all of us are kind of taught to like do that. So I just thought it's interesting because that contributes to kind of this complex PTSD that we probably, all of us in this room have in, one way or another.
I think that we certainly are all at risk. We all experience it. I'm a trauma surgeon, but I think the trauma and obstetrics is exquisitely similar, right? Hemorrhaging patient, benign gyn, hemorrhaging patient, benign gyn. You know what I mean? That's my world as well, right? I don't know why some of our brain stems, prefrontal cortexes and hypothalamus, there's all sorts of research and data. It's fascinating, right? I don't know why some form one way and some form another.
Yeah.
There's a sense of the being trapped, which seems to be the biggest trigger and concern, which puts us even higher at risk because I don't know about you, I graduated with $72,000 in credit card debt and $280,000 of student loan debt. The option of not going to work just wasn't on the table, right? I definitely felt at least financially trapped at the time. And I think compartmentalization, when is it appropriate, right? Like if I'm getting into the Uber and unloading and trauma dumping on the Uber driver, likely not appropriate. Absolute lack of boundaries is emotional dysregulation, right? When is it appropriate and how do we have these trusting relationships? So, you take a woman who can't form a relationship, can't sustain a relationship and doesn't know how to talk to anybody, grew up in a household that had a theme of don't talk, don't trust, don't tell. Go into surgery, which is like, there'd be more don't talk, don't trust, don't tell, compartmentalize, do your job, be the best. Put all that together and then it's like, go talk to somebody about it. I didn't know how to do that or even who to do that. You know what I mean? So the recognition alone that we are susceptible to it, I think opens up, at least for me, it opens up this insight of like, well, what would it be like if I talked to my colleague? I had Hope Jackson, right? The woman we cry together over charts. Like that was my go-to person in residency. And we kept each other pretty safe and sane. I think we need to also do a little bit better job of structurally building this out, especially for our medical students who are kind of observing a lot of what we're doing, but not there with us. Having an arc, because as a resident, I was rotating services every 2 to 3 months. And so if I'm having exquisitely traumatizing experiences on vascular, and then I'm in the ICU 2 months later, who knows what is happening? Some kind of touching base of like, where are we at? What is kind of happening throughout the course of our career? Yeah, thank you for sharing that. I think it can be a useful skill that we can overdevelop in a sense to protect ourselves.
Thank you for sharing your story. It was very touching.
You're welcome. Thank you. Only the second time I've done it, so I appreciate the warm welcome and the feedback.
You talked about how the committee, like a majority of the people that end up there are house staff, and you talked about how burnout kind of contributes in some way, shape, or fashion to some of the professionalism or other issues that people face. Are there structural changes going on in how training is conducted at OSU that seek to change? Because I think there's something inherently like bad about the way that we train physicians, and that leads to this kind of situation that people end up in.
So the answer is yes, at least there's efforts made for structural changes. And I can tell you that's an extremely important point, okay? Again, I'm a gastroenterologist. There was a study done among trainees in gastroenterology a few years ago, and they talked about burnout and wellness and so forth. And the important result of that study that I took was that they were kind of tired of hearing about the term wellness, okay? So they didn't think that those wellness structures that were in place at whatever institution they were at, I'm sure it wasn't Creighton, okay? or high state, I mean, anybody in there, wasn't all that helpful. And the reason was because they were hearing the same thing. Yeah, I know I should eat healthy. Yeah, I know I should exercise. Well, you don't need to tell me that. But the things that were the most helpful were what you just brought up, the structural changes. That if they were on call on a weekend, then Monday they were off. They didn't have to take a vacation day or come in tired. It was built into the system. We have a woman, Dr. Lakshmi Mehta, she's a cardiologist. She is our wellness program director for the whole medical center. Because so she has her role, her charge is to address wellness for the whole place in terms of those types of things, the whole population. Our committee, we deal with individuals. Okay, I don't do what Dr. Mehta does, and then she doesn't do what I do. We deal with the individuals who need help. She deals with trying to minimize the number of people that need to come to our committee. One of the things that is a huge focus at Ohio State and everywhere else that I've ever talked to or about is the EMR. You guys are on an EMR, right? Which one do you use?
Answer.
Okay.
Love having two systems.
So we use Epic, okay? But a big source of burnout and problems along those lines is the in basket. Does that resonate? Yeah, right. And I went to a wellness program 15 years ago. Okay, they were talking about it then. We're still talking about it. Okay, is it better? I think it is. I mean, if nothing else, yeah. Well, you guys aren't on a DAX Copilot, ambient listening. It's something that in Epic, it's something that works. So basically, you're in a room, you're talking to the patient, okay, and the computer, you know, the AI, whatever, is distilling down that conversation and basically writing the note for you. And it's pretty good. It's pretty good. Does that something, do you guys have that?
No.
They're working on it.
Okay. It's really good. I suggest that you try it. My practice is I have very minimal outpatients now. I don't use it, but the people who use it love it. And they say that it helps them with hours of documentation, hours in the EMR. So things along those lines, people, you know, like I said, Dr. Mehta, she's working on these types of things with others to help to, you know, mitigate some of the structural problems that can occur. The problem is that there's, you know, the solutions are never so easy. It's not, oh, fix this and then it all goes away. Problems are much more complex than that.
You know, I see this emphasis on wellness for the residents, but it doesn't translate into the attendings at all.
Yeah, that's a really, really strong point.
You know, there was an article in one of the OB throwaways written by Josh Capel, who's a maternal fetal medicine at Yale. And he wrote about how the residents had, you know, it was his weekend to be on, and the residents had changed and this and that. And here he, as a probably pushing 50 at the time he wrote it, was on the entire weekend, spending far more time in the hospital than any of the house staff.
Mm-hmm.
And, you know, I mean, it's great that they have that for the residents. Certainly when I was a resident, you could have gone in with a gun pointed to your head and all they would have asked is, are you a good shot? You know, how many bullets you got? But there is, at least in my sense, I mean, I don't know what, you know, some of the other attendings feel. There's no sense of that here as an institution for the attendings, or very little.
I think you make a really good point, because I think that one of the most heartbreaking experiences is you've just got to survive residency. It's only 4 years. If we keep making this promise that on July 1st, 4 years after you start, it's going to be okay. Right? And the reality is the only thing that changes is that your paycheck does change. You have slightly more control over your schedule a little bit, but it's not like you pick and choose which days you want to work, right? So there does need to be some institutional change at the attending level, because it's such a jarring reality 2-3 years out. We see it in all of our attendings. They come in first year, they're super excited about it. Second year, they're a little disillusioned. By third year, they're just angry. And either quit and go to another institution and go through that cycle again, or they stick it out and get into leadership and try to make it better, or just kind of acquiesce. So some of the things we've even done in our group is we decided last year, we're no longer working 24s, because 24s, you're on for 24 and you still go around the next morning. And I mean, you've got to be nearly decapitated, 4 o'clock in the morning for me to give a shit. That's how it goes, right? I'm not a good doctor. I'm gonna get you by, but I'm not a good doctor. I'm not a good human. So we agreed as a group, we're no longer doing 24s. We're gonna do 12s. And we get really good at our sign on, we're gonna switch every 12. And just that change was remarkable difference in our tolerance of rounding the next morning beyond for a whole weekend, right? We all agreed, we're actually not gonna argue for a pay increase, but we're gonna hire 2 more to fill all these other shifts that have now come up. So as a group, we said, we make enough, just hire us 2 more, and we'll all hold our salary. So there are some, this is just our division, right? There are some structural changes that we can start to put into place to make it better, because I think it's not just medical school, residency, fellowship, attending, but it's the whole arc of how we treat ourselves. I find it funny, by the way, that you have, was it, you said Osler or Halstead?
Osler.
Osler, okay. I thought it was Halstead. I'm like, the guy was a coke addict who used to take the
No, he
summers
was.
off. Yeah.
He
Okay.
was.
Same guy, right? Like, was a coke addict.
But they were both at Johns Hopkins, so.
Yes, so that's why we have,
That.
that's why we have rounds, that's why there's residents. These are the guys who developed residency back in the early 1900s. If you read a book called Genius on the Edge, you can find it. It's fascinating, like why we work the way that we work, because they just had the residents live in the hospital. That's why we were called residents. But anyways, over the years, and like you're describing, it's different. 20 years ago, it's different. 10 years ago, it'll keep getting different, but we keep pushing for continued improvements, right?
But there was, a really great point here that was just made was, and you asked the question, what structural changes are put in or worked on in order to improve burnout and just practitioner health and happiness? Where did this solution come from in trauma surgery? You guys, you did, you figured it out. We had a similar thing in gastroenterology. We would be on service for a week at a time. We would take call the entire weekend. And we came to the conclusion, we came to the realization, because people would switch a day here and there, that if we did it a day at a time, not to the service, but on the weekends and be on call a day at a time, it was much better. And we just morphed into that because we found that that was the best way to do it, and we were all happier. And so, you know, the point is to try to figure it out internally, what works for you, rather than rely on somebody else who doesn't do what you do.
Well, that's
To tell you
assuming
how to
that you
do
have
it.
administrative support and not intrusive administrators who decide things for you and don't, you know, I mean, you know, there's this incredible increase in hospital administrators. You know, JAMA had an article in the last 20 years, 3,000% increase in hospital administrators, all of whom's job is to make your life more miserable. And so, you know, when it's nice to say you guys went to 12 hours, but you know what? We have administrators who would have to approve that kind of thing.
And we do, we may be right now.
And so, you know, it may not be so easy to put some of those things into place, depending upon, you know, the administrators are saying, well, no, we don't want you to do that. So we don't always have control to that degree of our environment that, you know, I mean, I'm glad you guys were able to do it, but not everybody's in that situation.
And we did it, but it was in the shadow of 3 people had resigned in the past 2 years from burnout, and I had gone to treatment. Right, so it took a couple of crises to kind of get that support and that buy-in, but ultimately it is difficult, without any doubt. There's going to be barriers. We can overcome the barriers, and don't ever forget, we have the option to step away. It is inconvenient, it is expensive, it is uncomfortable, it might not fit with your life and our family, but we have choices and options at all times. And I lost this idea that I could walk away or quit or go somewhere else. It's never occurred to me. So I got sicker and sicker. And so we keep fighting and seeing if it gets better. And if it gets better, we stay. Keep making it better. You know, leave the campsite cleaner than when you got there. Try to make it better for the generations behind us. But maintain your own sense of, you know, being true to to thy own self, be true.
And when that becomes more in your wheelhouse in terms of understanding that, is when you get older. Now, I don't know, I think I'm older than all of you here, right? I don't know, but.
Not me.
But it's funny, you know, there's not too many benefits that come with age, but a few of them is having the ability or the options of doing what you want to do and even stopping working when you just are done with it. When you're in a situation, and you may even agree or understand why these administrators that you mentioned make the recommendations and the lines in the sand that they do. You say, yeah, I get that. But you know what? I just don't want to do that. I don't want to do that anymore. And that's when people have options to retire, or like I'm 69 years old, I still work full time.
I mean,
I told you I was older than
I did,
you.
I was like, what the, you got middle way. All right. I lived his life.
Well,
But I still, I work full time, not because I have to, but because I want to and I like it and I like working on it. I mentioned to you, I've spent my whole career at Ohio State, okay? And the reason is because I love working there. Notice I said love, not like, okay? Love is a visceral word, okay, as opposed to a functional like, okay? Have I gotten everything that I wanted? No. Has everything gone my way? No. Is every policy there something that I agree with? No. But for the most part, I've been treated nicely and fairly and appropriately. And I've had a few of my own health-related issues and supported every step of the way. And I really like working there. And so that's why I continue to do it. And that's what all of you should. You're all trainees, right? In a year, 2, 3, whatever, you're going to be looking for a job. When you look for that job, my recommendation to you is to look for a place that cares about you more than the bottom line. Now, that's easy to say, and you might say, well, you're not going to find a place like that, and maybe you won't, okay? But trying to, and understanding that they care more about you than the bottom line is a place that you should go to.
Yeah, well, it's not always so easy to,
It's never easy.
to
It's
change
never
a job, no, in terms of being, who's the primary breadwinner, moving children from schools, and depending upon how specialized your, medicine is, there may or may not be positions like, it's not like you can go from hospital A to hospital B. So, I applaud that idea of saying, yes, you look and say this isn't worth it, but it isn't always quite so easy,
And I didn't mean to imply that it is.
but. Well, thank you, guys.